Today, when we talk about EBUS, it's a very commonly used word. Almost everyone who's coming for training is using. But uh, how was it back then when nobody had it, and were you so sure that it would be a success?
Previously, we were never in the loop. We never were handling the patients with mediastinal lymphadenopathy. Usually, patients go from the CT route, and then from there it goes to cardiothoracic for a mediastinoscopy. So we actually never had an idea as to how big is this.
Can you just give us a short walkthrough as to how do you approach a case of mediastinal lymphadenopathy?
Yeah, that has gone through some kind of a evolution, I should say. Initially, we were doing everything on conscious sedation, and I think that's a reasonable approach as well.
So, what according to you are the most common mistakes that are done by a fellow or a new trainee? What are the do's and don'ts?
Dr. Atul Mehta's words, always be a champion for the patient, not for the procedure. You should be thankful that you are trained, but you'll have to have a responsibility in what you're doing. So I think that makes a lot of sense.
With great powers comes great
Responsibility.
Hi everyone, this is Dr. Samir Arbat. I'm your host for IP Unplugged, a very special podcast where we explore the science, skills, and stories beyond interventional pulmonology. Today we have a very special guest who needs no introduction and has been instrumental in progressing lung cancer staging and diagnosis in India. He's been the first person to have the EBUS in India and in Southeast Asia. Today we have Dr. Pattabhi Raman sir with us. Sir, welcome to this show.
Thanks, Samir. It's an absolute pleasure to be here.
So, sir, we are extremely happy to have you here. We consider you as the pioneer when it comes to interventional pulmonology. If I'm not wrong, you had the first EBUS in this region of the world in 2008, 2009?
2008, that's right.
2008.
Yeah, that's right.
Must be a completely different world at that time.
Yeah.
Before we start with the technicalities, can you let our audience know something about your medical school days? When did you think of becoming a doctor? What drove you towards interventional pulmonology? And how did acquiring the first EBUS actually come into picture?
I did my MBBS in 1988 in Tirunelveli Medical College. Tirunelveli Medical College it's about 80 kilometers from Kanyakumari. So we belong to the southernmost part of India. And then I did my MD in respiratory medicine in Madras Medical College. And those days there were only 3 seats in a year. So pulmonology was not very quote unquote popular then. And so I started my practice in 1998 in one of the corporate hospitals in Coimbatore. And that's a place still I live in now. When I was doing my pulmonary medicine, I mean, obviously, whenever we choose a specialty, that we look for what is the scope in that, and we had a reasonable idea about what could be done at that point, because bronchoscope was quite in the vogue then. And but we were confined to the lavages and the biopsies and so on, and TBNA was what we've heard about, and the lasers in electrocauteries were just 5-mark questions in our recent advances paper in MD respiratory medicine. So we had pretty humble kind of work as far as interventional bronchology goes. It was essentially a regular bronchoscopy, and thoracoscopy was just surgeon's domain. So that was there, and turn of the century, and we had, I still remember the APCB, which happened in 2004, I think, in Singapore at that point. And there was one conference in Mumbai where we had the famous trio from India who settled in US. We had Professor Atul Mehta, and Professor Praveen Mathur and Dr. Uday Prakash. And those people came here and gave a gist of what happens in the interventional pulmonology, and that's clearly inspiring. And not only for me, I mean, the people belonging to my vintage were quite enamored by that subspecialty, which is quite established at that particular point. So after that, we clearly were very keen on improving our thing. We were doing our basic pulmonary medicine, right? But this was something that was quite exciting, uh, and so roughly the time that the EBUS thing came up, this was a curiosity in the time 2005, 2006, and there was the first paper which came in 2006. And after that, I think I mean, we had one poster presentation in Chicago at one of the ACCPs, and that is when I listened to a lecture from Kazuhiro Yasufuku. That, I mean, we didn't know him then, but that hall was full, and that was a plenary kind of lecture about endobronchial ultrasound, and the way he described it, and I was completely kind of sold. So we clearly understood that this is the future, because the way he presented and the body of work that he did. And interestingly, he was a surgeon, and so he could kind of compare it with the mediastinoscopy. And that lecture clearly was an eye opener for me. And that's when I thought, okay, EBUS is there. And so at that point, there was not much of noise in our country at that point, but I got completely inspired by that talk. And then that was in 2007, and I think somewhere in October. So I came back, and then I discussed with my friend who's a cardiac surgeon in Japan. I just checked the whereabouts of Professor Kazuhiro Yasufuku, and then I wrote a letter to him. And then I also put in a word to my friend who is also a cardiovascular surgeon in Japan, and he talked to him, and Yasufuku sir was quite happy to give me. So I just thought I'll just go there, spend about a month there. And at that time, there was a World Conference in Bronchology in Tokyo. That was in March 31. I clearly remember the dates. So I thought I'll plan my trip. So I went about 6 weeks earlier. I spent my time there with Professor Yasufuku. In fact, I have to thank my colleague who was doubling up, and we were and we still are in a group practice. And so he took care of the 6 weeks, and I kind of went there for about 6 weeks, stayed there in the Chiba University. Professor Yasufuku was in Chiba at that point. And that is how it happened. I spent about 6 weeks kind of mentoring, looking at all that, and it was a very busy unit then. And so basic kind of introduction happened there.
But the basic, I would say, the idea of catching something at a very nascent stage. So today, when we talk about EBUS, it's a very commonly used word. Almost everyone who's coming for training is using. But how was it back then when nobody had it? And were you so sure that it would be a success? Did you have any reservations about getting an EBUS? And were there any compliance issues of getting such a complex machine in India, and also the local setting?
So interestingly, when I went there, I didn't really think about buying it. I just went to see how it is being done and have some kind of an idea, working knowledge about this, with absolutely no. In fact, my chairman, I just told him that I'm going to go there, and we never discussed about a formal procurement and getting it here in India and so on. So we just went there with an open mind and thoroughly kind of thing. I came back in March, and then I looked at the feasibility of having one such equipment in India. Now the thing is, at that point when we had to use. I mean, Olympus was not there in India at that point, so we had to move through dealers, and so A, there was cost, and B, there was difficulty in kind of passing the information on and getting your administration convinced about this, because immediately the question would be, what would be the indication? It's mediastinal lymphadenopathy, and so how common is mediastinal lymphadenopathy. So previously we were never in the loop. We never were handling the patients with mediastinal lymphadenopathy. Usually patients go from the CT route, and then from there it goes to cardiothoracic for a mediastinoscopy. So we actually never had an idea as to how big is this. And there was no concept of staging in malignancy in India. I think that roughly at that point, or probably later, there was a study from PGA where less than 3% of them came in stage 3A and earlier. A bulk of our malignancies, lung cancers, were stage 3B or 4, wherein staging wouldn't really matter. And the presentation was either a metastasis or, N3. So this was not a quote-unquote felt need in our country at that particular point. So after that, between March and, I took a couple of months to really look at all our data, just talk to people and see whether this is a valid kind of thing. Because at that point, our role was not about staging, because staging was never
mostly diagnosis.
Mostly diagnostic. And then we realized there's a huge number of nodes that are going on, and most of them were labeled as tuberculosis, and we started on ATT. Roughly the resistance thing became an issue. And so a lot of things happened together which could kind of help us convince the management. And of course, they were also quite happy, sitting in a tier 2 city, getting something for the first time in India. It was more of a curious and emotional decision rather than thinking about any ROA or pulmonary department in any multi-specialty hospital was not really considered, it's not the
you're not
the flagship
favorite
kind of,
child also.
Yeah, absolutely. So it's either a cardiothoracic, neurosurgery, and ortho. We would never get those eyeballs here. So thankfully we could kind of push our management to see some thing, and they were quite supportive, and so we got it at that point. There was no regulatory issues then, because it's just a machine out there, and so we had to spend a lot more because we had to open an LC and then get it from there, and so there's a lot of tax involved and stuff. But basically getting it here, there was not much of a issues with regards to in the legal process and so on. It was quite easy, but it was a long procedure, and we had to shell out a lot of money. But thankfully, there were a lot of referrals in the early days of procuring EBUS, and that's also I would definitely think we are in the border of Kerala, and Kerala is one of the most health literate thing, and so is Tamil Nadu, and so there were a lot of referral systems that were there. And those days, Kerala didn't have big hospitals. I'm talking about early 2000s, and so bulk of their cardiothoracic surgery were happening in Coimbatore. We share a border. Palakkad is about 40 kilometers, and so. We had both most of northern and mid central Kerala, and those mediastinal nodes were there, and so we got busy very, very fast. So we never had the a moment of regret for having got this, and it put our department in Coimbatore in the map of thing, and that's essentially my visiting card for of interventional pulmonology. And all other interventions happened after the EBUS, meaning I considered stenting and all that. Once we started diagnostic, and it kind of it made me be more responsible, and so expand the armamentarium from diagnostic. And then roughly the same time, Olympus had come up with the fluoroscopy, and so we could kind of get the whole thing called as interventional pulmonology.
Foundation which laid for the other interventions. Could you elaborate more on the technicalities of what used to happen before the EBUS? Because I think so all of us take EBUS for granted lot. But how were the days then, and what exactly used to be an anterior mediastinoscopy?
Yeah. So those days, if the nodes are huge, if there is anterior mass, and we had a strong cardiothoracic thing also, they did mediastinoscopy. So most of the 4Rs and 4Ls and at times 7 were handled with mediastinoscopy. And for the thing, for 5 and 6, they had to do Chamberlain's. They had to cut open and then do it. And no center was a huge, large volume center in lung cancer surgery, because lung cancer surgeries were never happening as much as we see it these days. And so, because again, the reason is it's quite advanced.
Yeah.
Non-small cell has always been stage 3B or 4, so it
First.
invariably stops, shuttled between a radiologist and an oncologist and back to the referring physician. And so we were never in the loop. These days, we're so lucky that we are in the loop from the point of our diagnosis, and then a staging process, and then we are back on palliating loop also. So there is a considerable movement between us and the oncology department now than ever before. The days when we started, it was essentially, we were trying to compete with the surgeon in terms of diagnostic thing. And so mediastinoscopy again was not a very common thing that happened in our country also, because most of the cardiothoracic surgeons, the cardiac side was more prominent than the thoracic side. So the number of thoracic surgeons, so to speak, has not been a great number. And thankfully we had one in our thing, so that there was, we were still aware of what was happening in there. And so we could see, and our thoracic surgeons started referring EBUSs to us, so that, he could concentrate on a surgery or decortications and the cardiac work. So thankfully mediastinoscopy, bulk of it came to us. So previously it was either a CT guided thing, if the radiologists were adventurous, or it's essentially belonged to the cardiothoracic surgeon. Well, nowadays we don't see those two specialties come to our way. By and large EBUS has replaced the whole thing.
So, sir, over the past 1.5 decade, how have you seen the EBUS scope evolve? I believe the first EBUS scope that you had was an Olympus.
Yes, that's right.
So, what were the dimensions then, and how was the image quality, and how have things changed?
More than the scope, the processors have come a long way now. We use the ancient one, EUC-60. It's a small box. A lot to be desired, but at that point it was quite okay, and we were quite comfortable doing that. And that was the only unit of EUC-60 in India, because from 2011, I think Olympus came with the EU-ME1, and so things got much better. That was a small box, and the scope was, dimension was around 6.9, the same thing. And I think the scanning range was around 50-55, and it was quite a bulky scope, and we had a channel was 2 millimeter. Now it's 2.2. Those were the differences, and we had the VisiShot 1, the earliest needles in Olympus that we could use. But again, it was a little more stiffer than what we get now. And the assemblies, there were minor differences, but that's nothing major in terms of thing. But it was a fiber. It continues to be a fiber, but the optics have improved a great deal, and then the flexibility has come up, has improved quite significantly now. But it did the work then, it does the work now. So now there are smaller scopes. The scopes are a little smaller, and it was a 30-degree forward viewing from 2008, and it's now 20 degrees because they've taken the ultrasound area is slightly angulated so that it becomes 20 degrees. So you see a little more, in line with the vision and so on. So those are the changes that happen. So it continues to be a hybrid scope, and so optics is remain the same, but the processors and with the newer thing, the ultrasound images are getting a lot better these days, and we have much better optics these days than what we used to have.
So when it comes to, I believe the first paper was from Dr. Yasufu. Dr. Chhajed was part of the team.
Chhajed was part.
When did you meet him in India?
So this is interesting. We've known about Chhajed, but 2007, the Chicago ACCP, that was the time I met him also. So after listening to Dr. Yasufu's lecture, I just met Chhajed, Prashant, who's now a very good friend. At that point, complete reverence. We spent about 30-40 minutes together, and after that, we had a nice, talk about it. And he was in Switzerland then. So I was asking him, but he didn't lose Bombay roots, but still he was
in Basel.
Yeah, he was in Basel. Yeah, he was he was full time in Basel then. So we spent about an hour or so on the way back to the hotel, and then we were discussing about the how is it possible to have this in India. And so we were just discussing. So he was also one sort of inspiration, because he was also a part of that paper. He was there in Chiba for about 6 months, and I got some of the contacts with him, how to manage in Japan for more than a few days and so on. So we had a very interesting discussion, and after that we conducted certain conferences in 2008, 2009, and Prashant was a regular faculty with us. And in fact, he was the first live demo that happened in 2008, 2009 rather, when the conference, in one of the conferences, we managed to do a live relay, and Prashant was doing it for us. And so he was a completely an inspirational figure as far as our
EBUS program is concerned.
EBUS program was concerned.
I'm sure you don't remember, but I had met both of you at ERS at Barcelona. That was 2010.
Okay.
And now when I look back, yes, that was too early a time to talk about interventional pulmonology.
Yeah,
yes,
possibly.
that was 2010. So now coming to your own practice with EBUS, we would like to know how exactly is your approach to a case of mediastinal lymphadenopathy? How many people are there in your team? What's your go-to process? Do you go for sedation? Do you go for general anesthesia? What is do you use an artificial airway? And also, do you have a on-site trap evaluation?
Yeah.
And can you just give us a short walkthrough as to how do you approach a case of mediastinal lymphadenopathy?
Sure. So yeah, that has gone through some kind of a evolution, I should say. Initially, we were doing everything on conscious sedation, and I think that's a reasonable approach as well. And so when you have a patient with mediastinal lymphadenopathy, we always were in a group, especially after getting into interventions. We very clear that there are 3 people in our team. All 3 are trained to do all the procedures, so that if there will be a 365 days cover with one of us at least being there. And we have a team which increased from about three more people who are helping to now we're on 15 people in our Bronx suite totally. So we initially did everything in a conscious sedation, and we didn't have a ROSE in the earlier days, from 2008 till about 2016. We were working with no ROSE. It was just a thing. So we had to go through the process in a certain predetermined fashion, where all the nodes have to be sampled, all the nodes have to be sampled at least 4 times, and so on. So we didn't have a ROSE, and so we did that. And also we found that quite all right as far as the yield went. We had something similar to what the literature told us, and so we were doing quite okay, as far as the yield went. Subsequently, when we came to another hospital, now we're currently working in another hospital. Here we have a bigger suite, and we have 2 suites, and we have more people. We have an anesthesia station in our Bronx suite, and so we do bulk of our work in
under general anesthesia.
Airway, under general anesthesia with supraglottic airway, and we find that supraglottic airway is the best way to do. The patient is quiet, and then we have the whole of trachea to play around with, so even a 2-hour duel will not be an issue. Now about 95% of our cases in endobronchial ultrasound, we've been doing it only with the supraglottic airway with an anesthetist around. We have trainees also. It's useful to have a quiet patient so they get the perspective of what's being done. So that is what we're doing now.
I believe that's a very personal choice, because there are many centers where good high volume centers where considering the time that it takes for a procedure to take place, mapping the lymph nodes, going for sampling, staging, so they often choose either sedation or general anesthesia on personal choice. What's your choice for the balloon? Do you always use the balloon? Do you seldom use the balloon? Do you never use the balloon?
No. So when a patient is thin and we are looking at a 4-hour where there are a lot of reverberation, we would like to use a balloon. It's not that we shouldn't use or thing, but bulk of our bronchial areas, we wouldn't really need a balloon, and so we wouldn't use it quite for every case. But especially in a 4-hour 4L situation, we would like to use a balloon so that you get a much better.
Yeah. Also, I think so. It's a matter of habit. I'm very much comfortable with the balloon, but I have colleagues who have completely forgone the balloon.
Absolutely.
That ways.
Yeah.
Also, how have you seen the shift when it comes to uh, tuberculosis, malignancy? Do you feel that now you're doing more malignancy cases? When did staging come into picture? How much of your work right now uh, consists of staging, or it's still majorly diagnostic?
It's still majorly diagnostic, but the staging has significantly increased, and that has happened because this is a process where the oncologists also have become more and more nuanced in their approach, and things are getting diagnosed pretty early, and there are a lot more of acceptance for CT thanks to COVID. There are a lot of stage
I
one,
think
stage
so.
two coming up,
A
and
good radiology support
yes,
has made a lot of
so
difference.
yes, radiology and oncology. So the concept of staging and concept of having EBUS, I think more people got into this field, the better. So if previously we were first people, and then there was one in Delhi in 2 years later, and another one in Chennai, another 6 months later, and then there were a few and far in between. But there is now a flurry of EBUS, and there are a lot more of people who are doing it, and so now there is a lot more of oncologists being aware, especially in training institutes. So once we have the necessary equipments in the training institutes, we'll have a lot more of people both in Department of Pulmonary Medicine, where intervention becomes a part of your curriculum, and the specialties, the core specialties that are important, like oncology. So people who did a DM in an oncology where there was a EBUS in their pulmonary department, and obviously go out and then start practicing. They'll be
Practicing the
looking
EBUS.
for,
Yeah.
so that I think it snowballed to a point where it started very few and far in between. In those days, it was very difficult for us to get get patients, convince doctor to send a patient for a thing. So initially, our spread was predominantly granulomatous lung diseases, especially tuberculosis, occasional sarcoidosis, and then previously when we started EBUS, we thought that sarcoid was not a problem for India, and we diagnosed a lot of them,
Yes.
and then we identified the sarcoid is not actually too rare, and now slowly from about less than 10%, it becomes now 30 to 35% of our thing, and a little more now. As far as the diagnosis goes, malignance, and some of them are staging also. Staging used to be very few and far in between, and it used to be a major event in our Bronx suite. Not anymore. We're doing a lot more of staging process because our oncology is also a busy oncology setup. Yeah,
I believe I've seen this across India. So centers who are associated with a strong oncology department are the ones who are doing more staging.
true.
Whereas otherwise, I would say it's a fairly equal space between
Yeah,
granulomatous diseases
yeah,
and malignancy.
absolutely.
Also, since you mentioned, I believe a lot of sarcoidosis that we've come across is all thanks to EBUS,
Yeah,
because I don't know how else would have
yeah.
that come into the forefront. How would we ever know that India has so many cases of sarcoid?
Absolutely, I agree with you. And sarcoidosis came because we had EBUS, and we knew that there were granulomas in a setting of in an appropriate setting. So it was always there, and EBUS was the reason why we could. Otherwise, it was a few pockets and where TBLB and TBNA were done very regularly. So in places where TBLB, and interestingly, in our growing day, 20th century, I'm talking about, not much of TBLB was an aggressive intervention.
Yeah, a
And
high
now
risk
high
procedure.
risk
Yeah.
procedure, and so that was how conservative we were. I think, and that's the reason why we missed all those sarcoidosis. It's not because EBUS showed us sarcoidosis. It's because EBUS is safer, and so
Yeah.
had we done aggressively, done the TBLBs, India would have identified sarcoidosis much earlier. We could see Dheeraj Gupta's team from PGI showing us there's a lot of sarcoidosis based on TBLBs and subsequently TBNAs. And TBNAs became a thing after 2005 or a little earlier than that. So I think these are the reasons why sarcoidosis is now being talked about. It never was it was just exam questions for us.
So maybe I can put it this way, that EBUS was the first stepping stone,
Yes.
because it made the procedure safe. Because this was a safe interventional pulmonology procedure, overall acceptance for interventional pulmonology procedures increased.
Yeah.
Also, it has always been the shining star for any department or a setup to have an EBUS, because once you get the EBUS, you do get more cases of biopsy, more cases of stenting. So I think so EBUS was the most structured machine that was available when it came to application of interventional pulmonology. There have been statements as to how EBUS has been the best invention after the stethoscope. Do you believe in that, or is it?
I personally believe it. Yeah, because that put me in a kind of pedestal that I wouldn't have otherwise got it. So, I mean, that's just a thing. But I think I like the way you set things up. EBUS was the first structured thing. So this, once you get into EBUS, and you called your diagnostic interventional thing, and so you right away are on a pedestal. And after that, since you diagnose thing, and you kind of become responsible for those patients, and so I mean, there'll be a reasonable level of skill set when you do that, and so it behoves on you to expand your skill sets further. And so the very small percentage of people would stop with EBUS and say, I'm just a diagnostic interventional guy. For everything else, I'll send elsewhere. So those days, I mean, it also is a phenotype. A person who wants to do this would also try to do
Other things.
other things, and so you form a thing. And especially when you're a team, you will have people who are like-minded, who would want to do push boundaries and slowly get more prominent. And that's essentially how the whole country had the crops of interventional pulmonology as a specialty growing up.
I believe EBUS is the only dedicated scope that we have. We still don't have a dedicated cryo biopsy bronchoscope or radial probe scope. So I think so EBUS put things very clear, crystal clear for everyone. Right. Coming back to sarcoid, could you just elaborate on what is your approach to a case of suspected sarcoid? We have so many papers talking about a MON2 positive and going for a endobronchial biopsy, transbronchial biopsy. What is your approach when you come across a case?
So if there is a sarcoid, we all know by now that sarcoidosis, 90% of sarcoidosis will be seeing it in one of our scopes, and CT is a fulcrum of it. And apart from, of course, clinical thing, and by definition, sarcoidosis is the diagnosis of granuloma after ruling out all the other things. And the way to rule out is to have fairly extensive clinical history taking, radiology, and the part of it will be bronchoscopy, both for diagnosing sarcoidosis and ruling out other stuff. So I think at this point we do, and it's also very useful in a sarcoidosis to have granulomas established in two different methods. And so one from the lymph node, other from either the airway or from the parenchyma. So in our bronch suite, when we do a thing, if it's a stage 1 kind of a presentation in a CT, we'd start with establishing a granuloma. Thankfully, from 2016, we have a rapid onset in our thing. So we keep doing till we get a granuloma. Once we get a granuloma, we don't stop there. We'll do a blind endobronchial biopsy, and bulk of them will get a that will only improve the robustness in which you make a diagnosis of sarcoidosis, because still it's a process of exclusion, and MAN2 is always there when we do a thing. So we'll have to do a MAN2 along with this, and then we make a diagnosis out of an exclusion. And it's usually robust if you find out a granuloma identified both in the lymph nodes and also in the lymphatic. So airways and transbronchial lung biopsy is when in a situation where if it's stage 2 or a stage 3 where we don't have a nodes, we'll have to anyway do blind endobronchial or a transbronchial biopsy. So a transbronchial biopsy, we do it when there is if you don't get a biopsy out of a node, or if the nodes are too small. But we'll always follow a positive granuloma in an EBUS in a node with a blind endobronchial biopsy in a sarcoidosis. And we can even do a cryo of that blind endobronchial biopsy, because that was also shown to improve the yield of a mucosal granuloma.
When was the first paper that was published from your end for EBUS?
Okay, it was a multi-center kind of situation. Interestingly, the first work of thing was, it came out as a commentary in Lung India in 2015, where we were talking about EUS-BFNA. And it was a kind of an editorial where our group wrote, whose tube is it anyway? I think we just were looking at why shouldn't we not do an EUS-BFNA. It was more of a point counterpoint kind of thing. It was an invited thing by for a Lung India, and that was our initial paper. Rest of it were multi-center thing that we were a part of. I mean, we had a good group of colleagues across the country, and we were doing a EBUS for a pediatric age group, and I think those were the initial papers that we had from our centers. So.
Yeah, so before we come to EUS-BFNA, I had a question. So EBUS is one of the most safest procedures amongst all. So what, according to you, are the contraindications that you consider where you won't go ahead with an EBUS procedure, or any special efforts that are taken while performing an EBUS procedure? Any subset of patients, any contraindications?
So any contraindication for a bronchoscopy is only contraindication for EBUS. So it's similar. I mean, if you're not able to maintain a hypoxemia, that would be the most important contraindication. So if the patient is quite puffing and panting with a lot of hypoxemia, and if you're not able to ensure that there is adequate oxygenation during the procedure, that would right away be an absolute contraindication. As far as other things are all similar to an active myocardial infarction and absent consent and trained people and untrained operators, and so these are the four major contraindications per se that ATS has given us. The other things that we'll have to be very careful about, coagulopathies, and the most important thing being whether this is going to change your way. I mean, in those kind of a compromise situation, we look at whether EBUS is going to change your diagnosis. Only then we kind of go in. So basic contraindication or absolute contraindications would be a patient who is having or had a very recent MI, or the patient has significant hypoxemia. So those are essentially contraindication for any bronchoscopy. EBUS per se doesn't add any contraindication because of the nature of this being a slightly bigger tube. No, it doesn't really.
Yeah.
And the fact that the needle goes in doesn't really, excepting maybe for a diagnostic bronchoscopy, you wouldn't look too much about the platelets. I mean, until it's less than 10,000, you wouldn't. Here, we'd like to have at least 50,000 platelet to do the procedure. So that is the only difference, because there's a needle that goes in. Other contraindications would be, I mean, can it be done into clopidogrel? Yes, it can be. There's been data to suggest that clopidogrel is not a contraindication per se. Of course, absolutely deranged coagulopathy, we would really do the needling procedures and so on. So those are the relative kind of contraindications which has to be in a case-to-case basis. But absolute contraindications is, apart from the lack of consent or poor training of the operator, the most important thing will be not able to maintain hypoxemia. That would, I think, be the most important. And a couple of mortality that has been discussed as a cause for a EBUS-related kind of a mortality, where unexplained. There's a couple of papers which kind of had to be added as a mortality for a EBUS was because of patient selection. The patient had a significant coagulopathy, and then they did a procedure, and following which there was a bleed. And since there was a DNR, they didn't really do further, and so the patient had to be shown as a mortality. So, per se, very safe procedure if it done in a proper and a safe manner.
Also, I think so the most pivotal question of this discussion is the diagnostic yield that is related to EBUS. So when we have physicians, doctors referring patients to us, and eventually the diagnosis comes as inconclusive, and then this is mostly for the young pulmonologist, young guys who are getting into intervention, and then they consider that no, so much of effort, but with an intervention we are not getting a diagnosis. I believe diagnosis of exclusion is a very strong point of EBUS. How do you look at it?
Well, yeah. So by nature of this procedure, you're just sticking a needle inside a big node, and so there is bound to be failures. I mean, at best the yield will be around 90s. And again, it depends on what you're doing it for, and if it's going to be a lymphoma, you'll obviously fall short. This is something that has to come in an informed consent, and the process of consenting, where we in our overzealous thing, which unfortunately we also did a lot. I mean, when we got the machine, we thought, okay, this is a be all and end all, and so anything I can make a diagnosis, and we find a lot of reactive things. A few things. One is, of course, the whole. There is a learning curve for everyone, including the people who call it. And the other things are, by nature of these diseases, lymphoma is very difficult to think. Post chemotherapy, making a diagnosis of a recurrence is an issue. In sarcoidosis, it might not be very easy. I mean, if you just confine yourself to say 3 or 4 passes, it might be. I mean, we've had it because we have a rose. We keep doing till we get a granuloma, and sometimes you don't even get it. Most of them can be dry and very difficult, and yeah. So there are instances very clearly, and that's the reason. It's not without a reason that the whole literature says it's around 80 to 90%, depending on the reasons why you do it. For malignancy, fantastic. It's upward of 90 plus, and for a staging, fantastic, 90 to 92. There is a very, very nice negative predictive value for a malignancy setup. But in benign diseases, there is always an issue. And the way to circumvent in sarcoid will be to make sure that you do the additional ancillary procedures like a TBLB, which we discussed about. And for tuberculosis, it's not only a cytology, it's about, microbiology, doing the CB-nats and the cultures and so on. So, all these have to be included, and when you do all these, still the yield is going to be anywhere between 18 to 85% in benign nothing. And lymphoma, don't even ask him. I can't really rule out a lymphoma by a thing. So if your clinical suspicion is lymphoma, we now have EBUS biopsies. I'm sure that's not going to be our area of discussion at this particular point, but we have certain ways in which we kind of address that gulf. But by and large, if you're looking at a lymphoma, or if you're looking at post chemo or a post treatment scenario for doing a thing, there will be issues in terms of negative. I think that's a, you'll have to talk about all these upfront to the patient and get that thing bridged. Expectation levels need to be bridged, and we'll have to say that there might be, these are not very these are very costly procedures for an average Indian, and we'll need to tell him, we'll need to drop the number, 10% chance of not making a diagnosis should come somewhere, either in the informed consent or a documented process, so that they know that there is always such a thing that exists. And we don't do that often early in our practice, and that is the reason why people are very disappointed. And so the communication is the key. And I guess there will be a small increment once you start getting better at the procedure. It comes to a certain point, and after that it plateaus because of the nature of this.
So what I see is, even with best of operators, at times you don't get a diagnosis.
Exactly.
So 2 points to consider. One, if it is malignancy, then not getting a diagnosis, it's a good negative predictive value. And if it is a benign disease, then obviously we need to see the patient as a whole, consider the labs, consider the bronchial lavage, and not just rely on the EBUS-TBNA report.
Absolutely.
So if that is considered, I believe it's a very strong tool for diagnosis and staging. Dr. Pattabhi Raman, when you started, what were the needles available, and what's your take on all the needles that are available now? How much of it is a commercial gimmick? How much of them have actually clinical application? What's your take?
Okay, till date, there has been no study that has proven a superiority of one needle over the other. So let's just keep that out of the way. There are a lot of needles with a lot more of logic and science rather than data. And it's ideal because it's not a single person's procedure. It is a whole team that is involved. And the needle is the most vital thing. People will need to know how the needle works, especially the assistant. I mean, it's not you, it's about the assistant. One false move can actually, cause a damage, and these scopes are not very cheap. So it's ideal for a unit to stick onto a single kind of a needle. So that is first thing, because there is no difference between the needles. There might be differences which might be more of logic rather than science. We've seen that there are some needles that are stiffer than the others. And in fact, the Olympus's latest 19 gauge is the most flexible needle. For instance, for a 4L, if I don't get it in a 21, I can put in 19 and scope flexes enough to, make a contact there. So I think there is a lot of work that is going on at this point. See, the thing is, in EBUS, you can see certain nodes and you can't needle them because the scope is flexible without the needle, and you can even see especially the left hilar and the left when 4L. These are the ones that needs a lot of flexion. You might see that, and you'll see a juicy looking node. And once the needle goes in, the scope gets stiffer and the angulation is not as much, and you might never get the same thing. It comes with practice to an extent, but again, there are certain areas which might not be very easy. For that, those are very small indications where at that point you might want to change the needle and see if a 19, in fact, 19 can flex a lot better than the other, I think, because of the make of the needle. Other than that, as far as my practice about the needle is, we'd like to stick on to a single kind of a needle. We've used Olympus needle all along, and we don't have any. We've tried other needles also. Not that they're not as good, but for me, it's more about the team being comfortable with the needle. It's better to keep it simpler, and that is the reason why we kept one batch of needle for a long.
So the reason I asked you this question is because with your experience and the amount of time that you've spent with the scope over the years, when it comes to us, like the new guys, we can discuss for hours for individual needles, because we put in a lot of brains as to how the newer needle is better, not better, more bloody sample, more tissue that we are attaining. But looking at a bigger picture, that's what I wanted to know from you, that actually how much things have changed with the type of needles that are available.
Yeah, it's very valid, but I can't call you a newbie. You are quite experienced. Second thing is, there has been clearly a data which has come out from APGI, which has clearly said there is no difference between the two sizes of the needle. And there has been differences between, again, Yashoda group, Nagarjunan group have shown that the Frasin needle is not really, these are out there as a data. It's not big enough when you compare it with the other cores. And so, I mean, these are the data that is suggested that, okay, it's not that you have different needles for different occasions, and it's better to have a single kind of needle for the whole team, so that it's a very comfortable process.
So now coming back to one previous topic that we had discussed was one is lymph node staging.
Yeah.
So what is your approach for lymph node staging? When do you consider going through EUS-BFNA? And what has been your experience of how many cases were earlier handled by the GI guys with their endoscopic ultrasound, and how many cases moved to EBUS or EUS-BFNA over these many years?
Yeah, this is a very interesting thing. In our case, both the hospitals that I had worked, we had EBUS first, and then EUS came subsequently. So we were kind of the boss there. So we didn't really have this problem. But it's a genuine problem, because esophagus gives an insight into, most of the common nodes, 7 and 4L, and at times if it's an enlarged 4R. So the gastroenterologist who is good in his interventions can actually sample the most common of the nodes that show up as far as the diagnostic work goes. And so as far as, if we started with the staging, so let's just start there. So staging obviously is a process in which we use only one needle for each thing, because needles are costly and we can't really have more than one needles. And that is the reason why we follow a certain order during a staging process. So for instance, if a patient has right upper lobe malignancy, so we look at N3, which is everything in the opposite side.
Yeah.
And then you have the N2, which would be the ipsilateral mediastinal. And then N1, which is ipsilateral hilar. So when you do the right upper lobe, we start off with the left hilar first.
Yeah.
So that's N3. And the reason why we do that is, using the same needle. So if you start the other way around, so if you start with an N1 is a very high likelihood of getting a malignancy there, especially in a setting of a non-ROS situation. So you do a N1, and then it is positive. And then using the same needle to go to N2, and after that, and then you go to the N3. And if you get something in the N2, it might be that the N2 is involved, or it could also be that the N1 cells can be contaminated because it's the same needle.
Yeah.
That's why we go to the farthest kind of a station, and then so we start off in this situation with right upper lobe malignancy, go to the N3, which is the left hilar first, and then go to the left hilar and the left paratracheal will be done. And after that, the N2 further distal N2 will be the subcarinal, and then you have 4R. So those will be the two N2s, 4R and 2R if it is involved. And then you go to the N1, which is 10R, and then 11R, and then 12R. So this is the sequence in which you go for a staging process. And we've done most of our staging again in a situation where we have a rapid onset also. So we could technically stop if it is called as a positive, but we could, also go through the whole thing. Now, how many nodes will you sample? If you don't have a rows, all the nodes need to be sampled as whichever that shows up. And having a PET before will give you some kind of a guidance whether you're going to sample everything. Also remember, the PET can be negative, but still the nodes can be positive in at least 9% of the cases. So that has been a trial that came out way back 2009, Felix here, that showed that there is a mediastinal negative, CT negative, or even a PET negative, especially in a setting of an adenocarcinoma, has a high chance of having a positivity. So we would like to sample every node that is in the process, especially if you're doing it in a non-rose kind of a situation. If the rose is there, we would still go through all these things. You can always stop whenever it is positive. So if you have N3 which is showing a florid malignancy,
you need not go at
you don't need to go, or you will go. And so these days we do a lot of molecular work, and the oncologists are demanding, and so we'll need a lot more of tissue sent for both for IHCs and more importantly for molecular markers, the next genome sequencing, and a PDL1. So all our samples, after we get it positive, we'll have to subject it for either an NGS and PDL1 right away. And so now the science is shifted towards molecular, and the treatment has been more of, I think, in a non-small cell slowly is getting into a realm of chronic infection, chronic disease rather than a life-threatening disease these days in bulk of adenocarcinomas. So I think we are exciting times where our role is very, very significantly important. So this is how we kind of stage a thing. What is the role of EUS-BFNA? Previously, when you used to do it in a conscious sedation, both for diagnosis and for staging. For diagnosis specifically, when it's in those specified areas, 4L or 7 predominantly, subcarinal left paratracheal, we'll do it, especially if the patient has a problem with oxygenation, a lot of cough. Those are the times where we could use hypoxemia, and the cough we could still use. The patient ventilated.
Yeah,
we've done that. Patient will be ventilated, and so you can happily go into the esophagus and do the procedure. So these are the instances where we could do a EUS-BFNA very happily. Patient's tolerance is extremely good, and it's no wonder that surgeons GI guys were doing bulk of the mediastinal work earlier. And when you do a supraglottic airway, then the chance of doing a EUS-BFNA comes down significantly.
Yeah.
And if we want it, we usually do it at the end of the procedure. After the EBUS is done. It's always, whenever you have both the things, you have to do airway first and then do the esophagus. So the time of patient coming off anesthesia, that is the point where we'll have to do. There are specific supraglottic airways for esophagus also.
Yeah.
We could also use that for a EUS-BFNA, but the number of times that we do EUS-BFNA has come down significantly once we moved on to supraglottic airway with the GA. Yeah. Otherwise, we used to do a lot of EUS-BFNAs before. So
also there's always been this question of lymph node characteristic.
Yes.
Fairly confusing.
Yes.
Contradictory data.
Yeah.
So what's your take on that?
Yeah. So my thing is simple. As of now, all the data has shown that answer is in the tip of the needle. It's not at the screen of the ultrasound. So there are things that can actually guide you. There has been a considerable improvement over the years, addition of ultrasound characteristics, Doppler characteristics, and now different Dopplers are coming up. There are different types of Dopplers. You have elastography that is coming up. Bulk of it is technology which has already been done for a different reasons. For instance, the liver elastography would make a lot more of sense. For GI, it makes a lot more of sense. But since it's the same processor, we try to invent reasons for the technology that's been already developed and see whether there is any application or the NBI and so on. So this also belongs to one such thing. There are definitely interesting, it makes interesting view and occasionally probably it will help you guiding your needle into certain places and not in certain other places. Doppler characteristics again can be, grossly to prevent you from making a very bloody aspirate. But again, there are different types that are described, type 1, 2, 3, 4 and all that stuff, which is not stood at the thing. It's nothing in the ultrasound at this point would make you decide whether I put a needle or not. That
you have
much
to. You
have to anyway.
Yes.
So when you are, short of that, it just, it's just an academic discussion. But ultimately, answer is only as you poke. So there have been differences, oval versus round.
Yeah.
Coagulation necrosis. And we've kind of found out the coagulation necrosis is not specific for malignancy. And we've had papers coming up which says it's tuberculosis in India has the same appearance as that thing. So that cannot differentiate between a malignancy and benign thing. And then again, the central structure, medullary structure, those are probably in a setting of staging to see whether the node might be involved or not. Those are the very, very,
but it has to come on the slide.
It has to come on the slide.
It has to come on the
Absolutely.
slide.
The needle has to go in.
So since you've seen things from the time of inception, what according to you is a part of future for EBUS? Obviously, we know that now the cryoprobe is being introduced. Yes. And there's a complete chapter that we can discuss about that.
Yes.
But there are also cases where the linear probe is now being taken to peripheral lesions. Yes. For diagnosis. So what according to you is the future for the linear probe? And how much does TBNA or an FNAC has a role in the future when it comes to respiratory diseases? Is it a tool that is fading away, or do you believe that it will always hold its strength when compared to all the other diagnostic tools?
Okay, so that's an interesting question. So the size of the probes, size of the scope has come down. It took 20 years to get 1 millimeter down. So that is the amount of work that has been done. So from 6.9 to 5.9. 5.9 is still not available yet. Yeah. Now it's 6.3 is what is they've managed. But 5.9 will find a lot more of applications. So the size of the scope, coming down would be a very futuristic thing. Once the 5.9 comes, that comes without a balloon, but that can go into the upper lobes. So at this point, it's not only about the mediastinal node and the staging. It can also sample the lung lesions around the
peripheral one-third.
The central one-third.
Yeah.
So 5.9 will definitely make sure that it's a 2/3 of lungs are covered, because it can go as far as the node goes. You can go up to station 13 and all that in the lower lobes, and it can go make sure that N0 is ensured.
Yeah.
And so the obvious follow-up is you're looking at early malignancy, where you use the same scope to ensure that there is these T status or the tumor status is established, nodal status is established, and so that you can go back to that, and then you can have the needles and you can have the other things put in. You can go for a therapeutic application. So not only diagnosing the peripheral lesions, you can also put in a radiofrequency catheter inside, or a microwave catheter inside, or a cryo inside, to ensure that you do both the diagnosis, staging, and the treatment in the same thing. So that probably will be what I will be thinking as you miniaturize. But then a long time, that's a long shot, but that is still out there, I think. So over a period of time, we've realized that the scope, it takes a lot of time to get it smaller and get it more peripheral. Instrument channel remains at 2.2, so we that's kind of standard. We can't really go beyond that to get more probes inside or bigger things inside. So because it will be at the cost of other things, and so there will be a 2 to 2.2 millimeter will be available as an instrument channel. There will be a lot of improvement in the ultrasound, obviously, and the convex array. They'll try to accommodate a lot more of the arrays, and so you get the scanning range, which is better. See, GI guys will look at 120 to 150, 160 degree scanning range, which means one half of the whole thing around will be seen. Whereas here, our scanning range is up to 110 max. So that can get increased. And I think, I mean, I'm a conservative thing. We belong to. So I mean, as far as relevance of cytology goes, I'm a conservative person. So I would definitely think that the cytology is here to stay. And there are people who think that, okay, just put in a cryoprobe and then be done with that instead of doing cytology. We have our own issues with that, because these are two different types of things. The needle can go to many places in the same node, whereas if you do a biopsy, it just goes to a single point. So I think these could be complementary techniques, but not a thing. So I wouldn't for a fact for a moment think that cytology will be out of vogue and we don't need needles again. It's just about cryoprobes and EBUS. No, I don't think that's how it works. So
Dr. Pattabhi, I believe you've had many people trained under you. So, what according to you are the most common mistakes that are done by a fellow or a new trainee? And what are the do's and don'ts that you think should be there for a newcomer, somebody who's just started using EBUS, learning EBUS? So, what's your take on that?
yeah, so my take might be a little archaic, but I mean, I feel that there is EBUS and there is a TBNA. So the EBUS part of it is there and the TBNA part of it is there. If someone is a good TBNA specialist, the conventional TBNAs, if he has done that, then half of your work is done. But these days, we are not really exposed to TBNAs because there are no centers which are doing, centers that were in training interventions have now switched over to endobronchial ultrasounds right away. So the ability to, we belong to a vintage where TBNA was the first thing that we did before kind of doing EBUS. So that is not there. So the most important thing for a newbie would be to have good exposure to things of C procedures, and then get assisted properly before moving on. And think about EBUS only after you've done enough number of bronchoscopies. So there will be an itch to start off with EBUS right away, but that doesn't work. I mean, like that. You'll have to be a good bronchoscopist before we get into the interventional aspects of bronchoscopy. So get at least 100 bronchoscopies under your belt before you really think about this. And it's preferable if there is a way you can get trained in a TBNA, so that you can do that, because ultrasound part of it is only a technical thing that you can master by just looking at going to places, looking at those things, whereas a TBNA is what you do. And also make sure that your team gets trained well. So to start off, you do big nodes, and you do the simplest ones that are straight on the axis, like a 7 or a 4R. That's bulk of your nodes anyway. Start off with at least a 2 centimeter above nodes. How to choose the node to biopsy? Usually, if you have a PET, it's well and good. You have nodes that are PET positive, and then you'll invariably have a yield. Or if you have other things like, you have a SVC obstruction, then you know that there is a right paratracheal involved. Never not go after that node. Similarly, if the patient has a left vocal cord palsy and you have a 4L node, always make sure that that's an involved node. So you know for a fact that that's an involved node. So when you go after the nodes, make sure that you go after big nodes or the nodes that have caused thing, or there are PET positive nodes. And there is also a learning curve for the pathologist. Always be quite.
I think so. Everything boils down to your pathologist, because
absolutely, you
no
do
matter how
rocket
good you
science
are, yes,
in terms of shoving this and shoving that, getting needle from a vague place, but answer is in that slide, and so you will need to be taking them along. It's not a single person thing. It's multiple people are involved, and everyone has to be in the same page. I have a feeling that people who have good bronchoscopists can get through this learning curve faster. ACCP recommendation says 50 procedures, so you'll need to do with under supervision. And to maintain it, you'll have to have a 25, because 50 and 25 are good numbers. I don't think it's based on any data. Some people learn it faster, some people take their time, but all of them can learn it. So that is something about this procedure. And the most important thing is, I mean, there are good simulators also available in that, and it's very useful to have simulator experience, because there are few simulators. They are in fact, you can rent them. You can't buy them because it's unless you're a big institute, they're very expensive. But they're good high fidelity simulators that are available, which can actually give you a lot of thing. And then bronchoscopy international is a very useful thing, and make sure that you do that 15 steps in EBUS. Is that be strong in what you're doing it. Have a bronchoscope suite, have that nodal station and thing. Be good in theory, have a very good mind, be good in your bronchoscopy skills. Remember, these nodes are, these scopes are very costly, and always follow the same, be obsessive about the, the way you do it. It's not, your team gets confused if you do one thing in a certain way and the next day you do it. Just try to follow a same pattern. The best thing about interventional bronchoscopy is if you have a protocol, stick on to that protocol. It's almost like an airline thing, You'll have checklist, you do protocols, you do it properly. Don't really unnecessarily do it because you think about this today and all that. It should not be that. If you follow it diligently, have an obsessive thing, and make sure that your team and the pathologists are all in the same page. And especially having an experienced pathologist in a rows in the initial days, that will give you, initially days, make sure they go after the big notes, the ones that gives you an answer, so that a positive thing will reinforce a good thing, and you get confidence in this procedure.
So even if you are a very good pilot, you need a good ground staff.
Absolutely.
And you need a very good air traffic control. So
Absolutely.
Can't happen without that. Because every year the number of people who are coming out as pulmonologists is increasing. The number of people who are keen on doing intervention is increasing. So I think the do's and don'ts are very important for everyone who wants to now get into intervention, start with EBUS. So Dr. Pattabhi Raman, there's this one very important question. I believe you are the best person to answer this question, and maybe you can give the right justification also.
You're putting me in too much pressure now.
Yeah. So all of us know that you are a big cricket fan, and we follow you so that we can follow cricket. So when it comes to Dhoni or Kohli, so what is your book?
Absolutely Dhoni. In my book, Dhoni goes up, not only because I'm a CSK fan, and we always have the CSK RCB thing, and that's why I think I would say again, Dhoni in white ball and Kohli in red ball is what my brain says, but my heart beats for Dhoni.
So we have a rapid fire question round, but I did a googly. Instead of introducing the rapid fire, I straight away went for Dhoni and Kohli, so that there should be some surprise element.
Absolutely.
So another question for you is, I remember days with the Duckworth-Lewis system. So what, according to you, was the most memorable time or the most controversial time? The World Cups, South Africa. So according to you, what do you remember is that one time you feel that no, this was not right and things could have gone the other way?
Yeah, the way Klusner was holding his hand and then looking at the asking it, suddenly going up from 1 ball 20 runs or so.
Yes,
that was really unfair. Absolutely unfair. That really gets etched in your memory. Life is not fair at all.
And you're a Sunil Gavaskar fan.
Absolutely.
Okay, so
I rate him as the best. Because it's easy. The days that he played, and the days you remember, you're looking at the Imran Khans, you're looking at the 4 quartet of West Indies, and there was no limit to the bouncers that you could bowl, and he didn't have a helmet ever in his life. So Viv and Sunny are the two inspirational figures.
Rivalries,
yeah, absolutely. And I think, till date, I think there's no one to beat Sunil Gavaskar. Of course, Sachin Tendulkar came close, but it's Sunny every day. Yeah,
it's always said that today's generation can't imagine how he used to walk up without an helmet. And stick there for hours till
Absolutely.
It used to get on everybody's nerves.
There's attrition game, leaving outside the house, knowing where your off stump is, and then play for the swing, and then you do all the basics right. Again, like an ATC thing, especially the first few thing. It might sound boring for people, especially the ones these days.
I think so. IPL has ruined everything when it comes to.
You look for 4s and 6s, the best ones are the attritional cricket. Thankfully, the India-England, the recent series have clearly got the thing back into thing. Those days, you could keep watching the way people plan their thing to take a batsman out, and how the batsman tries to, get out of
Defend
that.
for
I think
hours and days at a stretch.
absolutely. And those days were rest days. So it used to be 6 days.
Yes.
One day will be rest days. I'm
Yes.
sure you wouldn't know that, Samir.
I,
You were not
I
born
know the
then.
theory. I know the theory.
Yeah,
I've
I
been
know.
following cricket since
So either a
1992.
third or the fourth day will be a rest
Yes.
day.
Yeah.
So that was the time that you kind of look at what are the things, and how things were planned further. It used to be nice. And I'm from Tamil Nadu. Every Pongal, January, there will be a Chepak match, and we used to be glued to the radios those days. And I can't forget those period. Cricket was much better then.
Yeah. So keeping the age factor aside, I believe you are the Sunil Gavaskar of intervention pulmonology when it comes to India. You've been there since a very long time, and you've played the test game, whereas now we are very much into the short format IPL.
Absolutely.
But I think so everybody has to last for a very long time, and that's how it should be.
Absolutely. If you can't play it, you can also do a commentary probably, which is what I'll end up doing here. Want to stay in the game, but at least as a curious onlooker, looking with interest as to how things are proceeding. And I think exciting days are ahead for the young people. There are a lot more of technology that's coming up. But again, as they say, always follow the rules and follow.
And I believe no matter how much technology we have, everything is ultimately destined to be for patients' well-being and
Dr. Atul Mehta's words, always be a champion for the patient, not for the procedure.
Yeah.
I think that is one important lesson that needs to be inculcated among every young, proceduralist. Be a champion for the patient. I mean, you're doing it for a certain reason, and he's the one who's going to be benefited. It's not you. So you're not the hero there. You're just an enabler, and he gets a relief or an answer because of what you're going to do. And you should be thankful that you're trained, but you'll have to have a responsibility in what you're doing. So I think that makes a lot of sense.
So with great powers comes great responsibility. Dr. Pattabhi Raman, it has been an absolute pleasure walking down the memory lane, getting a sea full of knowledge and a perspective which is often not available nowadays. We are running really fast, really quick. Most of our discussions change on a monthly basis because whatever comes new, we are trying to catch up to new things. We are talking about AI into lymph node characteristics, EBUS and AI. But I believe what you have given is a very holistic and a very complete picture of how intervention pulmonology has evolved in India. You've been instrumental, been a pioneer and leading the charge when it comes to evolution of intervention, and we'll be needing your guidance, your support and your inputs always. So thank you, sir, for being here.
Thanks a lot, Samir. You're very kind, and absolute pleasure to share whatever I felt about this, and I absolutely love this.
Thank you. Thank you
so much.
So I hope you guys enjoyed this episode of IP Unplugged. We'll see you again in more episodes when we'll be exploring the science, skills and stories beyond interventional pulmonology. I'll see you again. I would like to thank Olympus for their academic support.